I think you just have to appreciate that it is not easy. You cannot make big, quick changes. That just doesn't happen in policy. And you might argue that that's not a bad thing because it does affect millions of Americans. You want to make sure that what we do is a good idea, is the right idea. And so that process of having to negotiate and, form coalitions and leverage and advocate, it's very time consuming, but it's the process we have. We can't throw up our hands and say, oh, well, you can't get anything done. And if you had told me in January that we would have gotten a bill in Congress, I would have said, I don't think that's possible, but it happened. So there you go. So I have an interesting perspective on advanced care planning because I am both a practicing clinician. So I work with patients and I help them fill out their advanced care plans, or I am asking their families if they had an advance directive. And then I'm also a policy person where I'm advocating for policies to support advanced care planning. And I would say the most recent and important project I've been involved with is in 2016, Medicare came out with billing codes to pay providers to have advanced care planning conversations. But those billing codes carry a patient cost sharing when that conversation takes place outside of the annual Medicare wellness visit. And we know now that there's data that cost sharing disproportionately affects communities of color and people at lower socioeconomic levels. And so at CTAC, we went to the agency that designates preventive services, and we asked them to designate advanced care planning as such a service. And they said that they wouldn't because Medicare, the Center for Medicare Services, CMS, had already designated it that way. So then we went over to Medicare and we said, okay, but it's only designated that way in one situation. Could you designate it that way anytime it happens? And they said, no, they didn't have the statutory authority. So then we just recently went to Congress and got a bill introduced in the House and in the Senate to take the cost sharing away and also let licensed clinical social workers be billable providers for advanced care planning. I need to share with this audience, this is a very political issue. So back in 2009, when the Affordable Care Act was being legislated, there came a lie, it was considered the lie of the year by Politico, that there were death panels that were going to make decisions for patients and pull the plug and take them off of life support. Totally untrue. But there was a provision in the Affordable Care Act that would have paid for advanced care planning, and they had to take it out of that piece of legislation because of this rumor. In 2016, very brave people at Medicare who all along wanted to do this said, you know what? We have the authority to just put out a billing code and pay people for this. And that was really brave because that was only 7 years later. And, they did it. So we were excited about the billing code and everyone was like, yeah. And then we realized, oh my God, there's this cost sharing. Well, there's always cost sharing if you have a Medicare Part B service, and that's a whole separate conversation. And don't ask me to go and explain that, but I could if I had to. There's always a cost sharing. I think everybody thought, oh, this will happen in this annual wellness visit. But the reality is that it's a code you can bill multiple times if you need to. So you could do it in an annual wellness visit. So let's say I have a patient in an annual wellness visit who has heart failure, and we have a conversation and we fill out the thing and they don't have to pay a cost sharing. Well, maybe 3 months later, they have a heart failure, crisis, and they end up going to the hospital. And as a result, their heart failure gets worse. Well, maybe it's a good time to have another advanced care planning conversation, right? That they made a decision 3 months earlier, but now things are different. Well, if we have that conversation and it's not, you can't do an annual wellness visit twice in 1 year, you can only do it once. So if we have that conversation, now they get the cost sharing. Or if they come into the hospital and I have that conversation with them, they get the cost sharing that they have to pay. And, it might only be $15, $20. It could be as much as $35 or $40. And so there was a really good, not a lot, but some research that had been done to say, okay, let's look at this cost sharing. Who pays it? And that's when we realized, oh my gosh, a lot of minority communities don't do annual wellness visits because a lot of them have trouble getting access to primary care. So they're having these conversations in the hospital, or they're having conversations with specialists, and they're getting hit with the cost sharing. Well, that's not equitable, right? I don't think anyone intended for this to be a service that the patient would have to pay for. And then there was additional research that said that some physicians, knowing that there was a cost sharing, didn't even offer advanced care planning to their patients because they thought, I know Mrs. Smith is having financial trouble. She's already told me she's having trouble paying for her medicine. I'm not going to engage in an advanced care planning conversation. Then she's going to get billed $35 for. I know I'm just not going to put her in that situation. So that was further reducing people's opportunity to have these conversations. So we said, this is a bad thing and it needs to go away. And that's when we started the track of, all right, we could all agree that what the problem was, well, how do you fix it from a policy standpoint? So then we had to talk to experts, say, all right, who has the authority in this area? And then what would the sequence be? And that's how we went down the track that we went, ending ultimately with Congress, because it turned out that they are the only ones who could make this go away. Well, I have to say, as a doctorally prepared nurse, that evidence was important. If we had not had good studies published in major academic journals, that we could have gone to people and said, this doesn't only sound like a bad problem, this is a bad problem, and here is the data that confirms that it is a problem. That got people's attention. Congress tries to actually, there is a federal law that says they have to pass evidence-based legislation, which is kind of a funny idea. So you can't bring crazy ideas to them if you don't have evidence to support. They just won't engage, and I don't blame them, right? So having good evidence helped push this further. Well, advanced care planning is this huge thing. There are so many components to it. And I think you need to figure out what component do you want to work on. So if you want to motivate people at the community level, go and look at the evidence, look at some of these resources, check with the Conversation Project, check with Respecting Choices, find the most effective way to have these conversations. Now, if you want to focus on clinicians, you have to recognize that I had special training to do palliative care. I mean, I was given communication training. Most physicians don't get that, nurse practitioners don't get that, physician assistants don't get that. So, people tend not to do things we are not so confident about, right? Or that we're very comfortable with. So if you want to focus on the clinician side, then you have to figure out, all right, could you work with medical schools and nursing schools to help train people? Can you help work with professional practices? If you are a primary care provider, I think you have an average of 12 minutes to see a patient. Advanced care planning, you can't even bill for it unless you spend at least 16 minutes in that conversation. So you have to appreciate that in a 12-minute visit with somebody who might have 4 chronic illnesses, you have no time for advanced care planning. So you have to figure out, if you want to help clinicians have these conversations, you have to find out a way to actually fit it into their clinical workflow. And billing is part of that. So those are things that could be done even on the state level and not on the federal policy level.